Hi everybody, welcome or welcome back to this channel, and this is the second video of this series where we are discussing the book called as Robbins, and this series is named as Read Robbins with Me, where we are getting some extract from the book of Robbins and we are trying to explain those important points based on that. And today's our topic of discussion is rheumatic heart disease, which is an integral part of the chapter called as cardiovascular system. Now, before we actually start about the disease called as rheumatic heart disease, we should know that rheumatic heart disease is a consequence or maybe a sequel of a disease called as rheumatic fever. People usually get affected by this disease called as rheumatic fever, which further on gets manifested as diseases like rheumatic heart fever, or it may also be like some glomerulonephritis caused due to the same. Now, what is rheumatic fever? Rheumatic fever is an acute immunologically mediated multisystem inflammatory disease, classically occurring a few weeks after group A streptococcal pharyngitis. So basically, first and initially there is group A streptococcus infection, and following that is an acute immunologically mediated inflammatory disease is known as rheumatic fever. Occasionally, rheumatic fever can follow streptococcal infections at other sites such as the skin. Acute rheumatic carditis is a common manifestation of the acute rheumatic fever and may progress over time to the chronic rheumatic heart disease. The rheumatic heart disease is characterized principally by the deforming fibrotic valvular disease, particularly involving the mitral valve. Indeed, the rheumatic heart disease is virtually the only cause of mitral stenosis. The incidence and the mortality rate of rheumatic fever and rheumatic heart disease have declined remarkably in many parts of the world over the past century as a result of improved sanitation and rapid diagnosis and treatment of the streptococcal pharyngitis. So, what is the basic clinical manifestation and which group of people are usually affected? It is seen in children of around 5 to 15 years mostly, but it can affect the adults as well. And this is an immunological disorder. What do we mean by an immunological disorder is that the immune system of the body is directly involved in this disorder. That is, the immune system or the hyper response and hypersensitivity of the immune system of the human body causes this disorder. So there is first, if you just take a history of the patient who comes to you with this case of rheumatic heart disease, you will find, and the greatest hint would be this, that a group A beta hemolytic streptococcus pharyngitis or sore throat history must be present of this patient. Now, let us just discuss about the pathogenesis of the disease. Acute rheumatic fever results from the host immune responses to the group A streptococcal antigens that cross-react with the host proteins. The characteristic 2 to 3 week delay in the symptom onset after the infection is explained by the time needed to generate an immune response. In particular, antibodies and the CD4 plus T cells directed against the streptococcal M proteins can also in some cases recognize the cardiac self antigens. Antibody binding can activate the complement as well as recruit the Fc receptor bearing cells, that is neutrophils and macrophages. Cytokine production by the stimulated T cells leads to macrophage activation. Example within the Ascoff's bodies. Damage to the heart tissues may thus be caused by a combination of antibody and T cell mediated reactions. In keeping with an immunologic basis of the rheumatic heart disease, streptococci are completely absent from the lesions. Now, because only a small minority of the infected patients develop this rheumatic heart fever, a genetic susceptibility is likely to influence the development of the cross-reactive immune responses. The chronic fibrotic lesions are the predictable consequence of healing and scarring associated with the resolution of the acute inflammation. So, what do we get in the pathogenesis of the disease? There is a cross reactivity due to molecular mimicry. This statement, let me mark it darker. This statement is the reason and pathogenesis of the disease called as rheumatic heart disease or rheumatic fever in general. What happens is, there are some specific antigens produced by the streptococcus which are similar to the proteins present in our cardiac tissues, at times in our lungs tissues, as well as in our tissues of the kidney. As a result, our body's immune system, while responding against these antigens, they destroy the self body proteins of these organs as well, as a result causing a malfunctioning and destruction of these organs of the human body. Now, antibody formation targets the M protein secreted by the bacteria, which has similarity to the glycoproteins of the heart, the central nervous system, joints, kidneys, and many more. So thus it is a type 2 hypersensitivity reaction which causes these antibody antigen reaction resulting in the rheumatic heart disease. Now let us get to the clinical features of this rheumatic heart disease. The rheumatic fever is characterized by a constellation of major manifestations like migratory polyarthritis of the large joints, pancarditis. Pancarditis means the entire pericardium gets affected, that is the myocarditis, pericarditis, and the endocarditis. There might be presence of subcutaneous nodules, typically on the extensor surface of the extremities. There would be presence of erythema marginatum, an irregular carcinate skin rash, and there might be presence of Sydenham's chorea, a neurological disorder with involuntary rapid movements. Chorea basically means some violent movements, and Sydenham's chorea is one type of that. The diagnosis is established in accordance with the revised Jones criteria, evidence of a preceding group A streptococcal infection, and the presence of two major manifestations or one major and two minor manifestations. The minor manifestations are basically some non-specific signs and symptoms like fever, arthralgia, or elevated blood levels of the acute phase reactants. Notably, these criteria are evolving and are applied differently in the low and high risk settings. Acute rheumatic fever typically appears 10 days to 6 weeks after a group A streptococcal infection in about 3% of the patients. It occurs most often in children between 5 to 15 years of age, but first attacks can occur in the middle to later life. Although pharyngeal cultures for streptococci are negative, by the time the illness begins, antibodies to one or more streptococcal enzymes such as streptolysin O and DNase B can be detected in the serum of the most patients with rheumatic fever. The predominant clinical manifestations are carditis and arthritis, the latter more common in adults than in children. Arthritis typically begins with the migratory polyarthritis accompanied by fever, in which one large joint after another becomes painful and swollen for a period of days and then subsides spontaneously, leaving no residual disability. Clinical features related to the acute carditis include pericardial friction rubs, tachycardia, and arrhythmias. Myocarditis can cause cardiac dilatations that may culminate in functional mitral valve insufficiency or even heart failure. Approximately 1% of the affected individuals die of fulminant rheumatic fever involvement of the heart. After an initial attack, there is increased vulnerability to the reactivation of the disease with subsequent pharyngeal infections, and the same manifestations are likely to appear with each recurrent attack. Damage to the valves in cumulative. Turbulence induced by the ongoing valvular deformities leads to additional fibrosis. This is a prime example of a common theme in a valvular heart disease in which the consequences of the valve pathology may contribute to the progression of the valve pathology in a positive feedback loop. So the clinical manifestations of the rheumatic heart disease appears years or even decades after the initial episode of rheumatic fever and depends on which valves are involved. So let us just get everything together. So basically, while we actually diagnose based on the clinical features of the rheumatic heart disease, we use a criteria called as the revised Jones criteria. Now, according to the revised Jones criteria, there are several major criterias and several minor criterias as well. But to fulfill the condition of a disease being marked as the rheumatic heart disease or rheumatic fever, the patient will have to show either two major criterias or one major and two minor criterias. Now, what are these minor criterias and major criterias? Let us just see. The minor criterias include some non-specific manifestations like fever, like arthralgia, like increased erythrocyte sedimentation rate, increased PR interval, and increased C-reactive protein. And as we all know, these three like ESR, PR interval, and C-reactive proteins are all inflammatory markers showing a case of inflammation. So ESR should be more than 30 millimeter per hour, and arthralgia is nothing but basically some kind of joint pain. Now, what are the major criteria? How do you remember the major criteria? You remember it in the form of by the name which describes this criteria, that is Jones. J for joints. So basically the large joints are affected and they have got migratory arthritis. The joints get affected with some kind of non-erosive arthritis, but which we can easily treat by using aspirin, which would give the patient some relief as well. O basically doesn't stand for anything, but we can say it as common. So we can just say it as most common. The most common causes are Jones. J. Now N. N has nodules, that is the patient has got subcutaneous nodules. These are painless and extalocation nodules, as we just read here, that the nodules are typically on the extensor surfaces of the extremities. Now let's come to E. E is erythema marginatum as discussed above, and S is basically Sydenham's chorea. Now Sydenham's chorea is basically seen in the latest stages, that is having to said a milkmaid grip. The patient shows some violent movements and they usually have a grip, a strong grip called as the milkmaid's grip. Now, in case of Sydenham's chorea, basically the CNS gets affected, the basal ganglia part of the CNS gets affected, causing the Sydenham's chorea. And C stands for carditis, which basically in case of rheumatic fever is pancarditis, that is all the three layers of the covering of the heart is affected, that is pericarditis, myocarditis, as well as endocarditis. Now, what are the morphological changes which are seen in case of acute rheumatic heart fever or chronic rheumatic heart disease? Now, what are these? During acute rheumatic fever, the focal inflammatory lesions are found in various tissues. Distinctive lesions in the heart, called as the Ascoff's bodies, are composed of the foci of the T lymphocytes, occasional plasma cells, and plump activated macrophages called as Antischau cells. So what are Ascoff bodies? Ascoff bodies consist of focus of T lymphocytes, occasional plasma cells, and also Antischau cells, which are nothing but plump activated macrophages. These macrophages have got abundant cytoplasm and central round to ovoid nuclei, in which the chromatin condenses into a central slender wavy ribbon, hence the designation caterpillar cells. So basically these cells have got abundant cytoplasm and caterpillar shaped chromatin fibers, and hence are called as caterpillar cells. During acute rheumatic fever, diffuse inflammation and the Ascoff bodies may be found in any of the three layers of the heart, resulting in pericarditis, myocarditis, or endocarditis, basically pancarditis. Now, inflammation of the endocardium and the left-sided valves typically results in fibrinoid necrosis within the cusps or tendinous cords. Overlying these necrotic foci and along the lines of closure are small vegetations called as verrucae. Thus, rheumatic heart disease is one of the forms of vegetative valve disease, each of which exhibit their own characteristic morphological features. Now, subendocardial lesions, perhaps exacerbated by the regurgitant jets, can induce irregular thickenings, which are basically called as macellum plaques, usually in the left atrium. Now, the cardinal anatomic changes of the mitral valve in chronic rheumatic heart disease are nothing but leaflet thickening, commissural fusion, and the shortening and thickening and fusion of the tendinous cords. The mitral valve is virtually always involved in chronic rheumatic heart disease. It is affected in isolation in roughly 2/3 of the cases, and along with the aortic valve in another 25%. Tricuspid valve involvement is infrequent, and the pulmonary valve is only rarely affected. So if we just talk about the frequency of the valves getting affected, then it is mitral, which is most commonly affected. Then the next valve to be affected is the tricuspid, and the last comes the pulmonary valve. Right? Now, in rheumatic mitral stenosis, calcification and fibrous breathing across the valvular commissures create a fish mouth stenosis or button mouth stenosis. With tight mitral stenosis, the left atrium progressively dilates and may harbor mural thrombi that can embolize. Long-standing congestive changes in the lungs may induce pulmonary, vascular, and parenchymal changes. Over time, these can lead to right ventricular hypertrophy. The left ventricle is largely unaffected by isolated pure mitral stenosis. Microscopically, valves show organization of the acute inflammation with post-inflammatory neovascularization and transmural fibrosis that obliterate the leaflet architecture. Ascoff bodies are rarely seen in surgical specimens or autopsy tissues from the patients with chronic rheumatic heart disease because of the long intervals between the initial insult and the development of the chronic deformity. Matlab, if we just take the specimen out of a dead body, we won't be able to appreciate the Ascoff bodies being present because of the reasons. Now, Let us just revise the clinical manifestations and the morphological changes that might occur in case of rheumatic heart disease, and most important of that is something called as pancarditis, because all the three layers, that is pericardium, myocardium and the endocardium, are inflamed, hence causing pericarditis, myocarditis and endocarditis respectively. So pericarditis is characterized by fibrin deposition. There is presence of pericardial rub and thus is known as bread and butter pericarditis, because it looks like those sandwich thing where there is presence of butter over the bread. So it is known as bread and butter pericarditis. Now let us just talk about myocarditis, which is basically the inflammation of the myocardium, and the characteristic feature, morphological change which is appreciated in case of myocarditis is the presence of Aschkoff body. It is present around the blood vessels. Aschkoff bodies are nothing but some plump macrophages. Now these are present in the plasma cells or F cells or myocardium, causing the formation of anti-scow cells or caterpillar cells, and caterpillar cell, the name comes from the presence of caterpillar shaped chromatin fibers. Now Aschkoff bodies can be seen in any layer of the heart, but it is most commonly seen in the myocardium and hence is an indication of the acute rheumatic fever. That is, the presence of Aschkoff bodies in the myocardium is pointing towards the acute rheumatic heart disease. Now endocarditis is nothing but the inflammation of the endocardium, and when endocarditis happens, the innermost layer of the heart, that is the valves, get involved. So valve involvement is present in case of endocarditis. The frequency of the valves getting affected is mitral, more than aortic, more than tricuspid, and more than pulmonary. In case of acute rheumatic heart disease, when the disease has for a short time affected the mitral valve, we face mitral regurgitation, the atrial valve, and there is formation of McCallum plaque, as we just talked about, and this McCallum plaque is localized in the left atrial wall itself. In the chronic rheumatic heart disease, there is presence of fibrosis and causes mitral stenosis, and whenever there is mitral stenosis, the valves appear as a fish mouth appearance or a buttonhole appearance, which we can appreciate in the figure. This is a mitral valve which has fibrosed and hence causes mitral stenosis, and this is a buttonhole of a shirt, as you can appreciate. Both of these looks similar and thus are buttonhole stenosis or maybe mitral stenosis, which looks like a fish mouth or a buttonhole stenosis. So with this we come to the end of this video. I hope you like this video. If you do, please hit the like button, subscribe to the channel and share this video who might find it helpful as well. And in the next video we'll talk about some other complications related to the cardiovascular systems and their pathologies. So stay tuned to this channel and subscribe. Thank you. All the best.